SPI to share the agenda. While we are sharing the agenda, just to thank very much to all the participants in this first GlycanTrigger Patient Symposium, and a special thank to the Portuguese Society of Innovation, which is one of the partners of the GlycanTrigger project. So GlycanTrigger is a big consortium dedicated to IBD prediction and prevention by tackling a very specific scientific research question related with the gut glycome, so the way that our mucosa is covered with glycans, with complex sugar chains, and how this is actually related with the early onset of IBD. So thank you very much to SPI for co-organizing this patients symposium. Also a special thank to the Portuguese Patients Association in IBD, and a special thank to Candida and to Filipa Cunha that kindly accepted to participate in this symposium. So as a Portuguese coordinator of the GlycanTrigger Patient Symposium, I'm very proud to have APDI here represented. Also a special thank to the European umbrella of IBD Patients Association, which is AFCA, the European Federation for Crohn's and Colitis Association, also one of the partners of the GlycanTrigger consortium, and for all of the help and to bringing the patient stories also to the agenda. And the last but not the least, a very special thank to our sister EU-funded project, Me Gut Health, here represented by Dr. Gwendalina Grafigna. I don't know if I pronounced it correctly, but it's a great pleasure to have here in the GlycanTrigger project, the Me Gut Health project, and to provide also your views on patient engagement. And also a special thank to our partners from our gastroenterologists in the consortium from Hospital Beatriz Ângelo in Lisbon, but also from Luz Hospital in Lisbon, respectively Dr. Joana Revés and Dr. Joana Torres. So the way that we will, carry out this symposium is by starting with a webinar, which will be moderated by Dr. Joana Revés, which is a gastroenterologist at Hospital Beatriz Ângelo, with a very specific research and clinical interest in inflammatory bowel disease, and is also one of the team members of the GlycanTrigger Symposium, in which we will discuss where we are in terms of prevention of inflammatory bowel disease. So then we'll have a workshop more on the role of patients' engagement in the management of IBD with the moderation of Dr. Gwendalina and also from the Portuguese IBD Patients Association. After a very quick break, we will end and finish this symposium with a workshop more dedicated to improve the health literacy in IBD. And this is one of our purposes of the GlycanTrigger project, is actually to have a direct impact in society, in civil society, in patients, in families, to improve health literacy in IBD. And this will be led by Joana Torres and by EFCAM, and to bring patients and their stories also to the audience. So the way, just to provide quick guidelines, the way that the webinar will work on how to engage and how to engage in these symposium sessions. So the first session on how we are, where we are in terms of preventing inflammatory bowel disease. So the first session that will be led by Dr. Joana Revés. So if you have questions, please write them in the Q&A box. Alternative, if you would like to participate in a more active way, please raise your hand and you can ask questions in a live way. So the second and the third session, the workshop on patients' engagement and the health literacy in IBD, please participate via Slido. You will have a QR code where you will be able to scan and submit your answers through the Slido for the real-time interaction. Nevertheless, If some questions and doubts remain, please send them all to this email address of the GlycanTrigger.eu, so contact@GlycanTrigger.eu, and we will be able to answer as soon as possible. So thank you very much once again, and it's my pleasure to introduce Dr. Joana Reves for the webinar on how close we are in preventing inflammatory bowel disease. So thank you very much, Joana, the stage is yours.
Hi, thank you so much for the introduction. So I will start by sharing my slides and hope it works correctly. Okay, can you see the slides?
Yes, perfectly.
Okay, so thank you so much for this opportunity for discussing this very challenging topic on how close are we to preventing inflammatory bowel disease. So I have a very short time for this very big topic. So I'm going to try to show you some of the most recent evidence and data that we have on prevention on IBD. So why do we need to discuss IBD? So we need to discuss it because this is a chronic disease that has no cure until now. So although we have a lot of therapies that are coming into the market, we know that actually more than half of the patients still fail therapy, and we are not able still to achieve a cure for the disease. And also we are talking about drugs that are associated with high costs and toxicity, and until now it is very difficult to achieve a drug-free remission. So by the time we start the therapy to a patient, one of the first questions that we are asked is if it is possible to stop therapy. So this is something that patients are very worried about, and also doctors. But actually, until now, we know that still half of the patients have a recurrence after stopping therapy. So it is still very difficult to achieve this drug-free remission. Also, we are talking about diseases that have high surgery rates, high disability, mental health comorbidity, and a very significant impact on patients' quality of life. And also the incidence of IBD is rising, mostly in newly industrialized countries. So we now see an increasing incidence in Africa, Asia, and South America, but also in children. And by 2030, it is expected that the prevalence of IBD in some areas of the world could be more than 1%. So it is really important to start discussing prevention on IBD. And we have a lot of things that have changed regarding IBD therapy. So we now have very stringent outcomes. We know that we want our patients not only to be in clinical remission, but we really want to achieve more stringent targets. We want to see a colonoscopy without ulcers, without inflammation. We are monitoring our patients much better than we did before. We now have access to the fecal calprotectin, a very good biomarker that we can use to monitor the disease. We have intestinal ultrasound that we can use on the bedside of the patient. But the new kid on the block that we're talking a lot now is this early intervention. So we know that, and this is more true for Crohn's disease than for ulcerative colitis, but we know that if we start therapy very early in the disease course, so after the diagnosis, we can achieve better results. So we can avoid complications, we can act on the inflammation and avoid the development of the complications of the disease. And this is a very recent study that was published this year and that provided more evidence for this early intervention. And actually, this was a biomarker-based trial. This is a very interesting point because the main objective of the study actually was negative. They were not able to confirm that this biomarker was good to stratify the patient risk and to select therapy. But what it could demonstrate, and that was very relevant, is that patients who started early therapy that you can see here on these blue columns that started more aggressive therapy in the beginning of the disease had much better results compared to patients who started what we call a step-up therapy. So patients who started with a mild therapy, let's say, and then when they had a progression of the disease, started a more aggressive therapy. So this provided evidence for this early intervention that we know we now need in Crohn's disease. But it is very, very important to say that IBD does not start at the diagnosis. So by the time the patient presents with symptoms and we are able to make the diagnosis of the disease, we know that a lot of steps happen before. We know that we have this genetic predisposition. We have a lot of environmental factors that contribute to the development of the disease. We have this process of disease initiation. So all the pathways that lead to the development of the disease. we have this subclinical inflammation. And this is very true because we know we have some patients that we diagnose even before they have symptoms, just because they made a CT scan or an exam that showed inflammation in the gut. So we were able to see this subclinical inflammation, and then we have the diagnosis of the disease. So when we are talking about moving this timing of the IBD therapy, maybe we should go even earlier. More than early intervention, we should go to the disease interception or disease prevention. And the question is, are we able now to predict IBD? And I'm going to show you some studies that are focusing and that are studying a lot about prevention in IBD. So there are a lot of preclinical cohorts that are looking at IBD across different life stages. And we have both prospective cohorts, so cohorts that are following healthy patients that are at risk for developing the disease, and then following them along the time to see the time they develop the disease. And we also have retrospective cohorts, so cohorts from patients that we know that already have the disease, and we have samples from the time before the diagnosis, and we can try to study some biomarkers that could help us predict the development of the disease. And one of these major studies is the GEM project study. So this is a Canadian study that is enrolling 5,000 healthy first-degree relatives of patients with IBD. So we know that first-degree relatives are at a higher risk of developing IBD when compared with the general population. So they are recruiting this at-risk population, and they are collecting questionnaires and samples, and they are following these patients along the time. And from these 5,000 healthy first-degree relatives, we know that some of them will eventually develop IBD. And what this study group is doing is then comparing biomarkers from blood, urine, and stool from the patients who developed IBD and those who did not. And I bring you here one of the results they had. So they were studying the intestinal permeability, and they were able to demonstrate that, in fact, those patients that later developed Crohn's disease had an impaired barrier function. So they had an increased intestinal permeability that maybe led to the development of Crohn's disease. And they had a 3 times higher risk of developing Crohn's disease along the time. Another very relevant cohort is the PREDICT study, and this is a study also that Professor Joana Torres, that you are meeting later today, is also very much involved. This is a study group from the United States of America that is using blood samples from military. So this is a study in collaboration with the Department of the Defense. And how were they able to do this? Because on the United States, the militaries were obliged to collect samples every 2 years to test for HIV by the time they were in the military service. And from this military group of people that were healthy in the beginning of the follow-up, actually some of them developed a lot of diseases, one of those diseases being IBD. And so we have these samples that we're collecting every 2 years, and we can use them in those militaries that later develop IBD, and we can compare them with healthy controls. And they are studying a lot of omics here in the samples, and you can see some of the results that were already published by this group. And I want to show you the results here from the first publication that they had, that they were able to demonstrate that there were some antibodies and some proteins that actually were increased in these militaries that later developed IBD, and they had a very high accuracy to predict the development of the disease. So they have a lot of samples, and they are making a lot of studies, and I think we're going to have more results soon. And also from the PREDICT group, they ask a very relevant question regarding a very specific group of patients with Crohn's disease. So they ask if the disease phenotype could be preset. And why did they make this question? Because we know that around 1/3 of the patients with Crohn's disease, already by the time they are diagnosed, they have a very complicated disease. So we know that 1/3 of the patients, when they start symptoms, they already have a stricture or they have a fistulizing disease. So this is a complicated phenotype of the disease already very early on in the disease onset. And they were questioning if this could be a different disease pathway from those patients that have a mild disease that has a progression later in life. and they could demonstrate that there was a difference in antibodies. So they find higher levels of ASCA and anti-flagellin antibodies in these patients that have a complicated disease at diagnosis. But also they found a high abundance of proteins that are related with immunity and fibrosis, and a low abundance of proteins that protect against this tissue damage and fibrosis. So these patients seem to have a different protein profile compared to those patients who have a mild disease that has a progression later on the disease course. And another very interesting study is here the tooth fairy clinical study, which Professor Werner Torres is also involved. The first results from this study were published in 2020, and this is based on the process of teeth development. So we know that our teeth develop in an incremental manner, and they can store all the exposures that we have in life from organic and inorganic products. From the moment that the teeth start to build in uterus, so by week 14, 19 of pregnancy, until the time they shed. So if we use these deciduous teeth, we can have a lot of information from all the exposures we had in between this time in uterus to the time of the early infants. And the first results published in 2020 demonstrated that patients with IBD, so this study was built on a Portuguese tradition of storing these deciduous teeth. This is something that we do here in Portugal. And so a lot of people has teeth in their houses, and we had IBD patients who had their teeth and also healthy controls that provided their teeth. And we were able to compare both of them. And we, as you can see here from the graphics on the right, patients who developed IBD later in life had a higher exposure to lead, copper, zinc, and chromium in childhood. So maybe these metals could be involved in the process of disease. And the study is now continuing, and we are starting to collect samples in these newly industrialized countries that we know the incidence of IBD is rising. So in the future, we are going to have further results with this study. And why do we need to identify these targets for prevention? Because the prevention of IBD may vary according to age and risk. So we know if we have a patient that is at risk, that it is exposed to environmental risk factors, maybe we can make some measures by some population-based measures. So we can try to modulate diet, we can try to modulate the microbiome. We have the question of smoking that we know it's very much associated to the risk of developing and having complications of Crohn's disease. So we can try to start measures to stop smoking. But if we have a group of patients that have some serum predictive biomarkers or have already a subclinical inflammation, so patients that are at a higher risk of developing IBD, maybe we could go for these individual targeted therapies. And I'm going to show you here some trials that are already trying to make interventions, so prevention interventions. One of these trials that is ongoing is the MEDLEY trial design that is focused on female patients with Crohn's disease that are pregnant. Because why was this study thought? Because we know that maternal IBD is a risk factor for the development of IBD in babies. And so what they are trying to do in this intervention trial is trying to use diets to modulate these risks. So they are trying to use an anti-inflammatory diet to decrease the risk of the babies having IBD later. And so they have these three groups of patients. So female pregnant patients with Crohn's disease that are taking this anti-inflammatory diet, female Crohn's disease patients that do not take the diet, and then a group of controls. And they are going to assess not only maternal outcomes, so they are going to see if this diet can really modify the microbiome of the mother and decrease disease activity, but they are also looking for baby outcomes. So they are going to see if they can modulate also the microbiome of the baby and also biomarkers of inflammation, here focused on calprotectin. So this is a very interesting study that we are going to have results also in the future. And I could not continue this presentation without talking about our GlycanTrigger project. So we already have very interesting results from this consortium that I think it's very relevant to present to you when we are talking about intervention. So this is one of the major publications we had now with this project. where the group from Professor Salmé were able to demonstrate that actually focusing on these sugars that are covering the gut cells, so the glycans, there seems to be a variation on this glycan that is covering here this antimicrobial antibody here, the ASCA, that is then favoring all the process of inflammation, so upregulating inflammation. So there seems to exist a very significant interaction between this antibody and the glycan that maybe we can modulate, and this is what we are continuing to study with this project. And what is the path forward for this prevention of IBD? So we have a few steps that we need to think about before when we talk about prevention. So we really need to validate and integrate these biomarkers. So I showed you some studies that are developing a lot of biomarkers, but we need to combine all this information. So we need to use the technology that we have available. We need to use artificial intelligence to really try to find a panel with the best biomarkers that we can use to have the higher accuracy to predict the development of the disease. Then we need to understand the preferences of people at risk for IBD. And this is very relevant because we can be able to identify those people that are at risk, but maybe people do not want to know that they are at risk and they do not want to take prevention measures. So it is really relevant to know what people at risk want to do. Then we need to set up the infrastructure to screen and identify these high-risk individuals. And finally, we need to start setting up disease prevention trials. And as I'm talking, it may seem too ambitious. It may seem that we are just going nuts and that we don't want to change the disease. But actually, this is already true for other very relevant diseases. So this is true for rheumatoid arthritis. This is true for type 1 diabetes, where we already had prevention trials that were able, so we were able to give a drug and then prevent the development of the disease. So maybe this is the path forward also for IBD, if we are able to select the group of patients. And focusing on this aspect of what people want to know about prediction and prevention, we also, our group at Hospital Beatriz Ângelo also developed the study with an international collaboration where we assessed the patients and first-degree relatives' willingness of going to predictive testing and preventive interventions. And the results were quite positive. So we see here that 85% of the patients with IBD or their first-degree relatives were willing to go to predictive testing, and 97% were able to go for preventive intervention. So this is very relevant for the future. And what is the future? So this is a graph that intends to resume all the information that I gave you on this presentation. So we need to identify the population that we need to monitor. We know that we have the first-degree relatives that are at higher risk. We know that from the general population, there are a group of patients that probably have a higher genetic risk, and we maybe in the future are able to identify them using this polygenic risk score. We need to know how to screen this population. So we need to develop this blood biomarker panel with all the biomarkers to then be able to categorize our patients. We need to be able to do this risk category in low risk and high risk. And within the high risk, we need to identify those patients that can have just a low risk intervention with healthy lifestyle measures, and those patients that need a high risk intervention and that will be candidates for this prevention trial. And so just to conclude, I think I showed you with this presentation that IBD, but mostly Crohn's disease, because we have more evidence for Crohn's disease, can be predicted years before diagnosis. We need to better understand the sequence of events leading to the diagnosis. So we need to understand all these pathways that lead to the development of the disease and to the diagnosis. The prevention strategies may offer the opportunity to truly modify the disease course and disease outcomes. And these collaborative efforts like the GlycanTrigger that we are here talking today are really needed for IBD prevention. Thank you so much, and I'll be willing to answer all your questions. Thank you.
Thank you so much, Joana, for the amazing presentation that provided an overview in different perspectives on where we are in predicting and preventing IBD. So the session is now open for questions. So you can put your questions in the Q&A in the chat, essentially, or if you prefer, you can raise your hand and you will be able to pose your question. So while we are waiting for the questions from the audience, Joanna, I have a question for you. So as a clinician, as a gastroenterologist, how do you see the prevention taking place in IBD? So we have these results and these clinical trials on RA. That was a drug intervention with abatacept, and the results were amazing in preventing the onset of RA in patients at risk. But how do you see it in IBD? Do you see it as a drug intervention trial, or do you see it as a dietary intervention or microbiome modulating therapies, which would be more, I would say, natural in a way of reprogramming the homeostasis in gut? So how do you see this?
Yeah, so that's a very interesting and relevant question, and challenging, because I think it really depends on the patient that we have in front of us. So I feel that now in my clinical practice, sometimes it's even difficult to convince patients to start therapy in those patients that we know that have an IBD, that have mostly Crohn's disease, because ulcerative colitis most of the times have symptoms already. So Crohn's disease, it's much more difficult. And it is sometimes difficult to convince these patients that they need to start therapy because there is already inflammation, although they do not have symptoms. So I think there is a lot of work here that we need to do on health literacy. But most of all, I think we need to understand the risk, because as I showed you in the survey, most of the patients were willing to go for dietary interventions, for intervention that could modulate the microbiome. But when we talk about drugs, they are a bit more concerned, although we had still 1/3 of the patients that were willing to take a drug. So I think we really need to identify these patients that are at very high risk, because for those patients, it could really make a difference if you could prevent the disease. I mean, for all the patients, it would make a difference. But if we could go for low-risk interventions, I think that would be easier than for these high-risk interventions. So we really need to find these biomarkers that help us to identify this group of patients. And I think that there is a lot of work that is starting now on this field.
Okay, so I have two questions here in the Q&A box. So the first one from Xavier Donnet. So is this great study valid for CD and for UC? I think you already answered that this is, I mean, this predicting evidence is pretty much on CD. However, we have these anti-integrin antibodies coming from actually one of our partners in Mount Sinai, from Professor Colombel's group. I mean, pointing some relevance of these anti-integrin antibodies in the preclinical phase of UC, but the majority of the evidences are in CD, right, Joanna?
Yeah, most of the evidence is on CD. So we have this anti-integrin antibody that was discovered on the PREDICT study, and it was also replicated on the GEM study. So there seems to exist a role for this antibody on UC, but most of the evidence is on Crohn's disease until now. Yeah.
Okay, so another question from Carolina, and the question from Portugal, and Carolina asked that she was wondering how patients will be selected for the clinical trial. So will patients already undergoing treatment be considered for the trials?
I mean, for the prevention trial.
I imagine that is for the prevention trials.
So these patients will be patients at risk, so patients without a diagnosis. So these patients will not be under treatment. These are healthy patients that we know that are at very high risk of developing the disease, and so they will be naive to treatments. Yeah.
So thank you. I think we can move on, and Joanna will take over now for the next session. So thank you very much for this nice starting of the symposium.
Yeah, thank you so much. So now we are going to move for the next workshop on co-creation of patient empowerment guidelines. So this workshop will focus on identifying barriers, sharing perspectives, and developing a roadmap to improve patient engagement. And I'm very happy to introduce Maria Stella. Maria Stella and Colitis Association, EFCAM, and so she will take the floor now. Thank you, Maria.
Thank you very much, Joanna. Thank you very much, everyone, and good evening, everyone. So my name is Maria Stella De Rocchis, and I'm project officer at EFCA. As Joanna was mentioning, for the next 30 minutes, I will moderate the workshop focused on exploring effective ways to reach patients in managing IBD. So the aim of this workshop is to collect and integrate the diverse perspectives and experiences of the participants to build a comprehensive understanding of effective patient engagement, and then to shape a roadmap together, a practical framework of the needs and priorities of patients by exploring current practices, identifying challenges, and learning from patient stories. So briefly, we will start with a presentation by Professor Gwendalina Graffigna. Then we will hear from two different patient stories from Candida Cruz and Filippa Cunha. During the session, we will also have some interactive questions polls as announced, and I encourage all of you to participate in this section. Once we have gathered all of your responses, we will move to a panel discussion where I will invite some of the speakers to join and contribute to the conversation. So just a quick reminder about housekeeping rules. You can please use the Q&A box to submit your questions, but also you can also directly speak, simply switching on your camera and join us when it's needed too. So having said that, I will now give the floor to first Professor Gwendalina Graffigna, who will present her lecture titled The Role of Patient Engagement in Managing IBD. So while you are uploading the presentation, Gwendalina, I will give a brief introduction of you. Professor Gwendalina Graffigna is a professor of consumer psychology and health at Università Cattolica del Sacro Cuore in Milan, and a consortium partner of another European funded project, MIGAT Health, in which also EFCA is actively collaborating. So, Professor Graffigna, the floor is yours. Thank you.
Thank you very much for the nice introduction. Thank you for organizing this workshop, because it's a very important chance to link as our effort in European funded project in this common area that is prevention of IBD. So I do not repeat anything related to the premises and the clinical relevance of this kind of project. Just I wanted to briefly give you an overview of the MyGut project where I work in terms of what are the main objectives that we have. So first of all, one main aim is to identify and validate gut health biomarkers. So the consortium leaders are microbiologists and geneticists that are working to understand what may be the biological and genetical markers that can prevent IBD. And this is because the second aim and the second ambition is to assess personalized prevention measurement in order to improve gut health, not only in already diagnosed patient, but in particular in the general population. But another very important ambition is to develop citizens' gut health engagement packaging strategies, because we really believe that prevention means, first of all, to sensitize the general population about the importance of changing behaviors or taking care of their gut health. And so that is why also myself and my group, together with EFCA, we have a very active role, because we try to boost the role and to study and to boost the role of health engagement in prevention. So like in this diagram, our idea is that the attitudes that people have towards health and prevention, and what we name engagement, that I will clarify in a minute. So in terms of taking responsibility for their own health is crucial in order to plan strategical prevention at the primary and secondary level. focus on health engagement, we have a specific work package. So you see here the overall structure of the project that is very clinical oriented, very hard sciences oriented, but it's also it also included a VP5, that is the VP we lead together with EFCA, that is focused on patient and citizens health engagement. And this is because we want to, first of all, to have some scientific evidences about the role of activation and engagement of citizens and patients in order to prevent IBD. And so we are exploring environmental factors and psychological factors and relational factors that impact on inflammation and impact on nutrition. And this is also because we would like to have some scientific evidences able to then be the basis for developing engagement toolkits able to educate patients, but also citizens. So here you see our three main objectives in our VPs, in our VP5. So first of all, we wanted to develop a theory-based and data-driven classification system of health and diet-related engagement risk profiling. So we believe that attitudes and behaviors are as well important as biological and genetic biomarkers, because of course it's related to epigenetics and it's related to all the environmental factors that may impact on the disease onset. But also we believe that it's possible to cluster different citizens and different patients according to their attitudes. And if we are able to segment the population on the basis of their psychosocial risks of IBD, then we may be better able to address and to create personalized health engagement information packages that are able to speak exactly to those targets. And as the third objective, we would like also to develop a personalized health engagement information initiatives, also with a blueprint with recommendation at the policy level. Now, in the title of my presentation, there is the concept of engagement, what we mean by engagement. But basically, we would like to realize the ambitions of having patients and citizens as part of their care team. So as an evolution of the patient-centered care model, where already was discussed the importance of taking care not only of the biology of the disease, but also of the illness experience and the sickness, so the sociocultural impact of the disease, the vision of patient engagement advocate for a participatory medicine paradigm where patients are considered part of their care team. Of course, in the full recognition of the clinician's role, that are the experts that need to orient the patients in terms of treatment, in terms of change of lifestyles. But also patients have an important knowledge, that is the experiential knowledge, and their experiential knowledge can contribute in order to improve treatment and improve their care journey. The idea of patient engagement comes from a growing literature, scientific literature. More and more research groups across disciplines, not only in psychology, but also in medicine and in general and in health, in different health domains, are studying what support the engagement of patients. And what is already known is that engagement is a process, is not a status, and that engagement is the result of a systemic action at different levels: the direct care level, the organization design and governance, and also the policy making. So moving from this very complex vision, we are trying to consider all the environmental factors that may impact on patient engagement. So the idea, the philosophy behind mind also that my gut is trying to foresee is that it's now time to move from giving the best service, healthcare service as possible to patient to the point in which patients should develop together with scientists and clinicians the best healthcare journeys as possible. And so this is in the VUP5 and not only VUP5. For my gut, it's very important to have the collaboration of EFCA and all the patients in order to really orient any strategies that we are embracing. And also the literature is showing how patient engagement is an important clinical factor because often correlate with better patient adherence, with better satisfaction and quality with care and quality of life. In general, it correlates with better health literacy, better preventive behaviors, and also there are some evidences of a cut in healthcare cost. In particular, in this broad literature about patient engagement, we are assuming the patient health engagement model as a theory. That is a model that was developed in a psychological perspective, and it's now broadly used across chronicities, but in particular we already collected several evidences in the IBD sector that depicts 4 phases, psychological phases of patient engagement, moving from a phase where people are frozen and blocked at the behavioral and cognitive level because of the impact of the diagnosis and the disease, until a phase where patients are more positive and motivated and feel they still may have a control on their disease. So in our previous research, it's particularly important to try to measure and assess the level of engagement of patients or citizens, because this is an important behavioral driver of how much people may be motivated to enact preventive behavior. So given those premises, very quickly, I wanted to tell you what have been the results that we were able to achieve in this first year of the project. We was a year and a half. So first of all, we conducted a review of the literature in order to understand what are the main environmental factors that impact on the IBD onset. And we saw that, of course, there are some socio-demographic factors, there are clinical factors, but there are also many psychological factors that are very important. In particular, we found that distress is an important factor that not only impact on inflammation, but also that impact in some way on food consumption. And on the basis of this, we then oriented our main hypothesis for the second task, that is a survey. So far, we were able to collect data over 2,000 patients and about 200 caregivers of patients, because we have 2 main populations we wanted to address that are patients, but also relatives or household, people that live with a patient, because we assume that also dietary choices may impact on the disease onset. So we were able to collect the data in Italy, and now I will quickly show you some evidences from the Italian database. But we are working to collect the data shortly in Germany, in the Netherlands, and also in Denmark, because we would like to cross-analyze the results. Our main hypotheses are that stress impact on inflammation, but this is from the literature, so we just wanted to confirm this. Then we assume that stress impact on stressful eating, meaning the frequency of comfort food consumption. And we consider comfort food things like chocolate, alcohol, or chips, or junk foods that we know are all very risky for IBD health. And finally, we would like to demonstrate that the level of patient engagement with the model that I showed before, and another construct, the level of psychological food involvement, that is how much people are conscious and invest mental energy in their food choices, is a protector of bad food consumption. So far, the hypotheses are confirmed, but as I said, it is preliminary database. And also, we were able to create these first two personas depending on the level of engagement, high level of engagement. Patients and citizens show a lower consumption, comfort food consumption when overstressed. They also have a low disease activity, a nice stool consistency, and a low perceived stress. On the contrary, patient and citizens that have a low level of patient engagement, they have a high comfort food consumption when overstressed. They consider comfort food a very important strategy to manage their mood. They have a nice stool consistency, low perceived stress, and a nice stress eating. So the work is ongoing. We are collecting other data. We need to make more robust our evidences. But we do this because the last task we are working now with EFCA is to develop, to co-design a personalized health engagement package. So basically, we are now collecting already existing educational material across countries that are dedicated to boost food literacy and to boost better food choices for IBD patients, and also that are dedicated to teach how to manage stress in a more effective way. And we would like to collect all those materials and to create a package that could be personalized according to the personas that we are creating on the basis of the evidences that I showed before. So I now need to close because my time is over, but I want to also just to mention that this study is also rooted on many other studies that, at least in Italy, together with Amici, that is one of the patient organization linked to EFCA, we have conducted, and we are trying to understand, for instance, also the role of stigma, how much stigma impact on the disease and the quality of life, and again, how engagement can be a good mediator of stigma. And we demonstrated in a paper that is just is under review, but with good reviews. So we hope we will publish it very shortly, that demonstrate again that the level of patient engagement boosts ability of patient to overcome stigma and to adjust in a better way. So I thank you very much for your attention and the occasion to share our evidences, and I'm happy to answer any question. Thank you.
Thank you, Gwendalina. Thank you, Professor Grafigna. Thank you very much. I'm looking at the question and answers. If I'm not saying wrong, I don't see any questions, but I have a question for you, Professor Grafigna. How can patients effectively manage, according to you, in your opinion, their diets and the stress eating behaviors? So which action can be done in terms of patient engagement, practical actions?
First of all, I think that notifying how food choices sometimes can be dysfunctional, but that we cheat on our diet because we need to manage our mood. I think it's already a step towards consciousness about those mechanisms. So, of course, people need to adjust with their stress. And also, of course, some foods are very nice and very comforting. But we can make people better aware of those unconscious mechanisms, and also to support them to substitute junk food, for managing their mood. So first of all, awareness. Secondly, I think offering some alternative behaviors that can be healthier, but also I think we need to sensitize the clinical community about this linkage, because so far psychologists treat stress and that's it. Nutritionists treat diet and that's finished, and gastroenterologists they treat the gut health. But we need to collaborate and to see all the connection, and I think those data may be a nice starting point.
Thank you, Professor Graffinia. I received a questions from one of our attendees. So what biomarkers are you looking at and in which preclinical cohorts?
So this is a very complicated question for me because I'm not a microbiologist and I'm not a gastroenterologist. So I would be happy then to refer this question to my colleagues in the clinical VPs. In general terms, an important chunk of research is focused on microbiome, of course, and to also understand how microbiome changes are related to some specific foods, because we have also a number of nutritionists and food technologists that are working on the consortium. So in particular, we are working on some cheeses and some dairy products and some fungus that appear to be particularly inflammatory in the microbiome. And then there are also some genes that have been studied, but I apologize for not being scientifically clear on this, but it's not my field.
Okay, so I think we have done with this
So we
session.
have,
Thanks a lot.
sorry, Maria Stella, sorry to interrupt. You can also see some two questions from Xavier in the Q&A box.
Oh, yes. Yes, I see from Xavier, our delegate from Belgium, the French-speaking Belgian associations. I can read, diet when you are not ill is very depressing for a lot of people and for me. Yes. And
Yes, it's true.
it will be very difficult to get potential future patients adherence. Yes, it's true. Thanks
Yeah,
a lot, Xavier.
yeah.
You want to comment on this, Professor
So
Graffinia?
I agree that it is the factor of adherence. It's a very challenging aspect, but that's why I think that understanding some psychological drivers can also help nutritionists and clinicians to find better motivating strategies for diet.
Okay, thank you. I think I'm checking both the Q&A and the messages. I don't see any further questions. Maybe just one more. Is there a profile of a person's character and mental health history which can be associated with IBD? Any
For
profile?
sure, mood disorders and in particular stress, anxiety, those have been demonstrated to have an impact on inflammation. Let's say that people that are better resilient in general and in particular in their disease course, they are better able to adjust and to control their emotion and to have a better balance in their emotion. In terms of personality, we do not have evidences, and also in the literature, there are not evidences of any specific trait of personality that predicts not only IBD but also engagement tendencies. So I think it's more better than personality. It's more about the relational environment where people live in, and also in particular the healthcare environmental. Because if patients are able to find a physician or a health team that is able to legitimize engagement and to motivate, then they adjust much better to the disease, and they also keep the level of agency and optimism to deal with the disease and the diet also.
Thank you very much, Professor Graffinia. So I think we are a bit behind the schedule, so it's to go to the next session. Then if anyone else has any other questions, you can address them during the panel discussion. So you still have time to do it. Thank you very much. So I would like to invite now to join the floor Candida Cruz, Vice President of APDI. APDI is the Portuguese IBD Patient Associations and member of EFCA, and Filipa Cunha, board member of APDI, and who is also actively involved in activities with our EFCA youth group. So Candida and Filipa will share their personal experiences as IBD patients, talking about the challenges that they face, the areas in which they feel patient education is actually most needed now, and share the view on the crucial role of the healthcare providers playing in managing IBD. So they will provide us with their personal perspectives into what effective collaboration and support from healthcare professionals should look like. So please, candidates, the floor is yours, and then you can proceed, Filipa, immediately after. Thank you.
Thank you, Maria Stella. Good afternoon. First of all, I would like to greet all the participants of this symposium and thank EFCA for this invitation. EFCA invited me to speak about the biggest challenge we face when we are diagnosed with IBD. From my perspective, the biggest challenge we faced is acceptance. Before understanding the treatment and the nuances of the disease, I think that first everything involves accepting that from that day on, we have a disease. This disease will be with you, that will be with you throughout your life. It's not easy. I still remember each word the doctor said to me when I was told 35 years ago that I had Crohn's disease. In fact, from someone completely healthy going to somebody chronically ill is a punch in the gut. It's very impactful and it's not easy at all. And we can't forget that IBD usually occurs in young adults at the height of their dreams and projects. In my case, I was diagnosed at the age of 28. I just opened my law firm, which I closed this very same year, turning my life upside down. Everything was strange to me. Then we have a long journey of understanding the disease and its treatment. And this journey is also difficult considering that the disease is very unpredictable. It can have a lot of manifestations, many complications that greatly limit our quality of life and which can even prevent us from having a normal life. To help us understanding and manage the disease, I think it's very important two things. First, that we can have a gastroenterologist and a nurse specialized in IBD available to explain us the disease, as well as a specialist in the field of psychology and nutrition. This team as a whole will make the difference in our life. Second, training people with IBD is fundamental in all areas. As we always say in IBD, a well-informed patient is a better treated patient. I will highlight the importance of empowerment and advocacy action. And on the other hand, sharing knowledge and experience with other patients is also very important because the feeling of belonging, that we are not alone, is very important. For this reason, the Portuguese Association, APDI, holds several face-to-face and online meetings to educate and inform patients, and to get together is very important. Finally, I would say that when designing new medicines and clinical trials, It is essential to involve patients from the very first moment. We can make a difference, and I'm sure that therapeutic adherence will be much more effective. Thank you so much for your attention and for this invitation.
So now I think it's my turn, right, Maria Stella? Yes, okay. So good afternoon, everyone. So I am Filipa Cunha, and I have ulcerative colitis for 10 years old since I was 18. So I'm currently a member of the board of APDA, the Portuguese IBD Association. I'm also coordinate of the youth group of my association, and also I'm part of the EFCA youth group. So about the biggest challenge that IBD patients can understand about their treatment pathway, I think one of the biggest challenge that many patients face, that are already faced, is the complexity of the treatment plan. Often the information comes in medical technical terms, which can make it difficult to understand what is really going on with our health, with our disease. Another challenge is something that I face every day, is that IBD doesn't come alone. So we need to be followed by multiple specialties and multiple healthcare professionals. And we often are followed in gastroenterology, nutrition, psychology, dermatology, and more. So in most cases, maintaining the communication between these health professionals is really a challenge, which makes sometimes the treatment of IBD really complex. Another challenge that I faced sometimes is the lack of time for healthcare professionals to explain the chosen treatment for us, and to explain how the medication works, or even the importance of taking this medication. And I think that can even doubts, or can lead to doubts, or can even let patients not taking the medication because they don't understand why they are taking. And now I want to highlight some areas that I think the patient education is needed. I think that an informed patient is a patient who really will reach remission faster, and will be a patient who will always take their medication and make conscious choice in their IBD journey. So I think that is very important to have a patient education. One area that I think there should be more patient education is patient empowerment. Teaching patients to be managers of their own disease is very important. This should be included knowing how to listen to their own body, recognize the first signs of a flare, knowing how to react if they have a flare or something, knowing what is important to say at the doctor appointments to help the doctor to help us and give the best medication, the best drugs for us. Another area is the advocacy. I think it's very important to patients to know their rights, and in their country's health system, education in this area can help them defend their needs, basically. Another area that I think is important to educate patients is the managing of their own disease, helping with strategies to deal with day-to-day symptoms, knowing, for example, the importance of health, of mental health or nutrition in managing their IBD. And I think one of the most important areas, which is one of the areas that I'm working, is that the importance of educate patient to participation in support groups, show how beneficial and helpful their participation in supported group can be, listening to the experience of others and talking about their own experience can help us overcome the challenge and difficulties of living with IBD. I can give my personal experience. I am in two support groups right now, the Portuguese youth group and the EFCA youth group. And I'm pretty sure that being in those groups are one of the things that got me in remission these days. So I think that's my opinion about this area. Thank you.
Thank you very much, Candida and Filippa, for bringing your personal perspectives. Thanks a lot. We will discuss also later on with you about what you have shared with us. I don't know if we have time for the poll questions. We are a bit behind the schedule, but if you want, I can proceed with it. I don't know, Salome, but I will ask everyone here to stay a bit longer than 7 p.m. Central European time. Okay, so let's proceed first with the poll questions for the audience, and then we will discuss together the answers from Candida and Filippa and from the attendees. So you have to answer these questions, as said before, by scanning the QR code here on the left. So the first question is, what are the biggest challenges in understanding your treatment pathway? So let's wait a few seconds to see if we receive any questions that we can integrate in the next panel discussion. It's taking time, of course, because you have first to scan the QR code and then to answer. So let's wait a bit. But once again, the clarity of the work process, and this is something that we also heard from Candida and Filippa. So better understanding of the treatment options, better understanding of the disease. So we have a patient biochemist, so it's been easy to understand because of course it has some background experience. So the several parameters that influence the chronic state and taking medicine for always. So okay, and I will be waiting for other patients to come, and then we can move to the next question. But I already seen that something, of course, is recurring. And while we are waiting for the responses, Candida also reconnected to what Professor Grafigna said before, the need of having a multidisciplinary approach to manage the disease, which is really important from the birth perspective. So from Gwendalina Grafigna, from the patient's one. So the different names of the drug, yes, once again, so and a full understanding of the treatment, the chronic state, the clarity of the work process, and okay, it's clear. I think we can move to the second questions and the third questions too. So in which area do you believe patient education is most needed? And I don't know if Joanna Revs or Gwendalina Grafigna, you want to comment on this while we are waiting for the responses. So
Yes,
nutrition is one of them,
yeah.
yes?
Oh, sorry. So I was thinking as a clinician of the different answers that we had on the previous question, and also on the participation from Candida and Filippa. And actually, I think there is sometimes a communication barrier, and also because we have a very limited time in our appointments, and that is very relevant because when we have a patient that has a diagnosis, we have to give information about the diagnosis, we have to explain what is the disease, we have to explain that it's a chronic disease, and then we have to explain the treatment pathway. And I think sometimes it's our mistakes also as doctors. I think we need to work on patient education, but we also need to work a lot on our communication, because sometimes we just give a lot of information and it is very difficult to get all the information needed. In my hospital, for instance, we also have a nurse appointment that we use a lot afterwards. We give the main informations and then the nurses help to understand everything that we said in the appointments. But I think it is very important to work on patient education, because I think, as both Candida and Philippa said, a patient that knows what we are talking about, knows the information about the treatment, can manage better their diseases and can help us make the decisions, because it's a shared decision most of the times. But there's still a lot of work on our side also.
Thank you, Joanna. Here I see that the most typed is nutrition. So in which area do you believe patient education is not needed? That the majority of our patients unanswered nutrition. Okay, we can move, I think, to the third one, and then we can discuss together with also the other panelists. What role should your physician play in managing your IBD? And what we could see, so from Candida and Philippa, so in terms of the role, so the role that the healthcare professional should play is something about educators. So in an educative way, they should understand patients and also engage with them. So let's wait for explaining clearly what's happening, explaining conditions and treatments in simple ways. Okay, closer relationship, importance of adherence. This is something that we also discussed before. So yeah, for friend, I mean closer interaction, considering comorbidities and talk with other colleagues. So again, the multi-stakeholder approach, which is very interesting. And let's wait for the open space. So some safe place in which you are confident and secure to talk about your disease. I can imagine. Let's wait for the last one, and then we will move on. So I see one participant is typing. So safe space again. Okay, I think we can close. We have sufficient material to discuss about. So let's move now to the panel discussion. I'd like to invite to join the floor all of the people who joined us so far. So Salome Pino, Joanna Reps, Gwendalina Graffigna, Candida Cruz, Filippa Cunha, but also Luisa Vedano, the EFCA CEO, who has been with us since the beginning. And so I would like to invite her as well. So to improve, first of all, to improve patient engagement, it's clear that that addressing the challenge that even other patients share that it's necessary. So some subject to discuss about. So understanding, better understanding of the disease, better understanding of the treatment, the need of multidisciplinary approach, the need of education, nutrition, mental health, and also lack of time that already Joanna Reps addressed. So first of all, I want to know if you have any comments on this. Otherwise, I have questions for Luisa, Gwendalina, and also Joanna again. I think we can move with the questions. So Luisa, starting from you. Filippa mentioned the support groups, so the role of patients associations like APDI and EFCA. And so they can play an important role in providing researches, education, and also bridging the gap sometimes in understanding and empowering patients to take an active role in the disease management. So we just talk about the personal experiences, but I would like to ask you, Luisa, in your role of CEO of an international organization and also as a patient, how do you think that evidence-based data can contribute to this patient engagement process?
First of all, good evening, everyone. I'm really pleased to be part of this discussion. It's really enriching and even emotional, and it's always very important for me. Well, I think that what is really important, and I try to give you the point of view of an association that is currently regrouping more than 40 national associations. So we have to take into consideration different cultures, different approaches to the disease, and also different health systems. So we are talking to an audience of patients that not necessarily have the same rights as Philippa was mentioning. Where are my rights? Which are my rights? Which are my limits? What can I get? What I will never be able to get? And unfortunately, sometimes it really depends on where you are born or where you live to get access or not to treatment. So what we are trying to do is to collect all the information we have from our members. That could be surveys, scientific data, registries, and also very often even the information we get from more informal events, and try to elaborate from this data that are evidence-based data a more scientific approach to define unmet needs, priorities, and to try to identify some of the most important messages when it comes to advocacy and when it comes to training in general. Just to give you an example, a few years ago, we started talking in our community a lot about clinical trials, and we also realized that particularly in Europe, there is a decline of investment, generally speaking, in clinical trials. And the first operative proposal we put at disposal of our member was an academy. We have an online university, and the topic of the academy was clinical trials, because it was something that was really a priority for our people. And I'm pleased to mention that we are talking about people with IBD in our organization, because, of course, we are dealing with patients, but patients are first of all persons and people, and for us this is very, very important. So coming back to defining priorities, I think that when anytime you are able to show that some needs are based on data and scientific data, every time we can do this, we can reinforce the advocacy, the empowerment, and also the visibility of our community when it comes to talk with physicians, medical societies, payers, and decision makers, because this is also very important. We can claim all our rights, we can want to get better access to new drugs, etc., but then we need to convince those who are deciding. And putting together all these elements means having data, solid data, to show and to for better claiming our rights.
Thank you, Luisa. Thanks a lot. Here I see we have received a question from a patient. So a chat from Andrea Fernandez. So a challenge for me was during my internship abroad to have offered by my hospital medication for a long period, because I was not planning to go every 2 months to the hospital pharmacy to have immunosuppressor. I was kilometers away. And so this is a challenge that it's often happening when you are living with IBD and you are planning to go abroad.
But may I just add something, Maria Stella? I think that here again, the role that patient association, I mean national ones, and second level associations like we are, is crucial, because we can really bridge, it was Candida, but also Philippa were talking about the importance of exchanging experiences. Whenever we get in touch with someone who is aiming to travel, no matter if it is for tourism or for study or because they're seeking for a new job, we try to identify and talk to our members and see which can be the easiest way to get access to treatments and to find practical solutions. Because I think that when it comes to deal with the chronic disease, practical solutions to problems are a priority. So being practical sometimes really can improve the quality of life.
It's true. Yes. Candida, you have a question.
No, I'm not a question about only. In fact, APDI in Portugal, we do a lot of this work, putting our members or not members, everybody that asks for our help, we help them to get treatment in the countries for wherever they go. And we, many times, and Luisa knows that, we ask help from EFCA and from the other national associations, because it's important for us to go for a country where we know that you are going to be well treated and nothing is going to miss you. So we do that. And I think all the national associations all over Europe do that.
Yes, it's true. Thanks, Candida. Quite recently, I helped a mother from US to relocate her daughter in Spain, and she was asking me who should contact to follow the treatment and whatever. So it happens really frequently. So thanks a lot. Thanks a lot for giving your perspective on this. I think we can move now to the last sessions. So we have discussed about the patient engagement, so highlighting the relationship with the patients, between patients, healthcare professionals, but also patient organizations. Now I want to move to the final session, which is mostly focused on empowering patients by providing them with the the necessary research they need to make informed decision. So I hand over now to Joana Reves and also Dr. Joana Torres, who will and she will be moderating the final workshop. And I don't know if you want to have a 5 minutes break. Otherwise, we have for another 30 minutes.
We can move on. Yeah, I think for the sake of time. Yeah.
Great. Thanks a lot.
Thank you.
Okay, thank you so much, Maria. This was a very interesting session. So now we are moving to the workshop on health literacy in inflammatory bowel disease management. And I'm very happy to introduce Professor Joana Torres. She's a gastroenterology in Hospital Beatriz Ângelo, but also in Hospital de Luz de Lisboa, that are partners here of the GlycanTrigger project. She's the master of IBD prevention, and she will talking to you about tools for self-management and health literacy in IBD. Thank you so much, Joana.
So thank you very much. Thank you very much for the kind introduction, and hello everyone, and congratulations, Salome and GlycanTrigger project, EFCA, for organizing this symposium. I've been listening to the last conversations. And actually, what I'm going to say, I think, has already been kind of discussed by the patients, and I think they've kind of highlighted many of the unmet needs that they may feel being a patient living with IBD. So this is a very short presentation. I actually had to think a little of what I was going to present, because this is something that we, not always as physicians, we kind of reflect how we can best empower our patients. And I think, of course, is through helping patients getting the right education about their disease. So, if anyone who has been diagnosed with a chronic condition, whatever that chronic condition may be, I think it's kind of usually people want to understand their condition. And so if you have been diagnosed with IBD, of course, Crohn's or ulcerative colitis, I think understanding what are these diseases is really crucial. For patients to understand the symptoms and to understand the type of symptoms that they need to be vigilant about, and also understand how they can help to manage those symptoms. Many patients identify a lot of triggers for their symptoms. I must say that often these are not well studied in the literature, or may not be valued by your physician if you're a patient with IBD, but that doesn't mean that it's not a trigger for your condition or for your flare. And understanding the triggers for your IBD or for specific symptoms in your IBD, such as anxiety or fatigue or even abdominal pain, I think can be very helpful, because then you can also have a role as a patient to proactively manage those symptoms. And I think, and that has also been discussed, I think, by the patients, by Candida and Philippe, and also by some patients in the chat, that understanding the treatment options really gets complicated, and understanding the benefit-risk relation in all those treatment options. And unfortunately, not always physicians take the time or have the time to discuss adequately with their patients to involve them in the treatment decisions. And I think this generates a lot of anxiety and a lot of fear by the patients. So I think, to communicate with the physicians and really aim to understand the treatment options, I think it's essential. So something that I think it's very important that as patients, and we also as physicians realize, is that inflammatory bowel disease is very, very variable from patient to patient. And so this is kind of a very simple schematic of what is inflammatory bowel disease in terms of the evolution over time. So we have this preclinical period, which is a period where there is no diagnosis. So we can also call it a pre-diagnostic period. Some people already have some unspecific symptoms that maybe are not correctly evaluated for IBD. We are still learning about what may be some type of specific symptoms that physicians do not think about IBD. But after this preclinical period, which is actually what GlycanTrigger is also, the project is also trying to uncover, there is essentially the diagnosis, and then physicians start a treatment that may induce remission. Some patients will go into prolonged remission. Some patients won't respond to that treatment. Some patients will have a very on-off course with a lot of flares. So I think it's very important to understand that it's a very dynamic disease. It's very variable from patient to patient. It's very heterogeneous. We don't have good biomarkers to know which patient will respond to which therapy. And so I usually say that, each patient is a patient. It's not Crohn's disease or ulcerative colitis. So it's very important to communicate with patients and with patients groups, but it's also important to understand that if two patients have Crohn's disease, the therapeutic options may be very different, just because, of many factors that go into that decision. And so it's also very important to communicate with the medical team to understand why. Something I think which is quite striking is that many studies have shown that there is a misalignment between what patients feel as the most bothersome symptoms for them and what physicians may think are the most important symptoms. And so this is from a survey that has been conducted in the United States. And you see that the symptoms that really had a most impact in patients' quality of life were fatigue, anxiety, low mood, depression, urgency, bloating, need for toilets soon after eating. And you can really see that what we as physicians typically ask, which is abdominal pain and diarrhea, it's really coming lower in the list. So I think this is very interesting. And when you kind of also compare the patient and physician reported symptoms with the greatest impact on the quality of life, in light blue you have the patients, and in dark blue you have the physicians. Again, you can understand that what patients feel that impacts greatest their quality of life is not necessarily what the physicians may be. And it's actually quite interesting because I'm in clinic, and so I was just seeing a patient, and she told me, I just want to have better quality of life. And I thought it was maybe about, because she had perianal Crohn's disease. And I asked her, so what do you think what's most important for you to improve your quality of life? And she said, it's improving my fatigue. And so this is just to highlight that, we need to communicate better with each other, both patients to physicians and also physicians to patients. And this is a survey now in ulcerative colitis. And you can see here that 78% of patients said that their quality of life was affected, but 50% did not discuss this with their physicians. And it may be for a variety of reasons, because they feel the physician is with little time, under pressure. They may feel ashamed to speak about this. But it's true that also physicians, and you can see here, only 23% of the physicians regularly discuss the impact of ulcerative colitis here, but I think it's exactly the same for Crohn's, on mental and emotional well-being. So you as a patient, also need to help us as physicians improve. So I think it's very important to ask questions. So don't hesitate to ask your doctor or nurse any questions you have about your condition, treatment, or lifestyle. And also you need to remember that physicians are often very concentrated on the treatment, the endoscopy, the biomarkers. And so they may need to be reminded about things that maybe they will not discuss in their first, approach. So you should ask your physician, and you should actively listen what your physician also has to say. You should make notes if there is something you are not clear about, and then you can reflect and you can ask again. You can ask for clarification, and you should express what are your concerns. And this is very important when it comes to navigating the treatment options, because it's not unusual for patients to go online and read about treatment options, and to completely, it's very difficult to understand the treatment options, especially the safety. And so, if you don't ask your physician, if you don't understand why that decision is being made, what's the risk, what are the benefits, it's very, I think, difficult for a patient to engage in that treatment option. So ideally, treatment options should be, of course, based on shared decision making, where the clinicians, of course, propose what they think is the best based on the guidelines, experience, and the evidence, but also that it's adapted to the patient's lifestyle, values, preferences, and also personal goals for the treatment. So many patients, and I think this has already been discussed here today, really want to know about their lifestyle management and self-care strategies. And we are very bad in offering advice about that. And the reason is that we don't know what's the best advice to offer. But generally speaking, proposing our patients or advising our patients to eat a Mediterranean diet or exercise, try to sleep well to avoid fatigue, try to implement strategies for stress management, will promote better lifestyle and health in general. And so I think it can make our patients feel more resilient and be more prepared to face, for example, a flare of IBD. So we already discussed here today the importance of patients to advocate for themselves and to empower themselves. And I think that really the best strategy is to get informed about what is IBD, what's the expected disease course for that individual patient, what should the patient expect in terms of the treatment, what are the symptoms that the patient should survey, etc. And of course, to get appropriate education, it's very important to find reliable online or non-online, but I think today a lot of people resort to online resources and also support groups. And so each patient at their own country have the patient association. We have here patients from APDI. There are amazing resources online. There are several patient association, also the EFCA, which is the European Federation of Patients. There are support groups. There is the opportunity to find people that can share their experiences and also share, how they have overcome difficult situations. And there are a lot of apps today for everything, essentially. So, for example, I think a lot of patients have a lot of problem managing stress and anxiety. So there are a lot of meditation apps. There is food apps. There is an IBD diet checklist specifically designed for Crohn's disease. There is apps to keep track of symptoms, apps to keep track of medication to avoid forgetting medication. And so all of these self-management tools can potentially be individualized to patient needs and help those patients, manage specific aspects of their life and of living with IBD. So I think indeed IBD patients face a lot of literacy challenges. I think it's our responsibility as physicians to educate the community of patients, to also educate patients' families, because I still see, and we are always seeing patients, first-degree relatives that are already have someone in their family with Crohn's or UC and are still living, too much time with symptoms before they get help for diagnosis. So it's also very important to educate the first-degree relatives, in my opinion. And so it's for sure, I think, we as physicians, we see many patients, but for that individual patient, it's a life journey living with this chronic disease, and we fully understand all the implications and the impact it may have on the quality of life. So I do believe that it's for us to really communicate clearly with our patients, to try to provide educational materials, or to direct our patients to the IBD nurse or to the patient association, to be open to discuss what questions the patient may have. Because for sure, if patients know better about their disease, they're, I think, much more equipped to deal with disease, but it's also very helpful for us as physicians, because the patient will be more likely to be compliant with the medication or to understand the symptoms, to identify early symptoms of a flare. So for sure, that education provides patients with the tools and techniques to cope with the physical and, I think, emotional challenges of IBD as well. But I think as a community, I think there's a lot of work for sure to be done still. So thank you for your attention. And I think this was my last slide. And thank you very much.
Thank you so much.
I'm happy to take questions.
Thank you so much for this very nice presentation. I was looking here for the Q&A. So we don't have a question, but we have a challenge. That we need to update the book for patients for IBD self-management that was published in 2010. So maybe this is a challenge for the future of something that we need to do to update this book. And since we don't have more questions, I'm just going to make you a question, because I think we are a bit late on the session. It was very interesting to see that there was this misalignment between the goals that the patient wants and the goals that doctors want. But I think that for us doctors, it's also challenging, because most of the clinical trials are not focused also on these goals. So most of the trials do not talk about fatigue, anxiety, depression. So it's really difficult to know the impact of treatments on these symptoms that are so relevant for patients. So what do you think is the future? Should we look more for an holistic approach? Because we have a lot of patients that are in remission for us, endoscopic remission, clinical remission, biomarker remission, but still have these symptoms. So what do you think that we need to do?
I think, so this is actually something that concerns me a lot, because some clinical trials are already incorporating other layers of symptoms, besides the usual disease activity symptoms, because, and usually there's some correlation between fatigue, sleep, and other kind of quality of life metrics, and symptom resolution and inflammation resolution. But as you said, some patients won't have any disease activity that we can measure, at least, but they have a lot of fatigue. And this is, I think, a very, very burdensome symptom, to kind of always to have to drain themselves out of bed, to feel completely like a foggy mind. And so we don't know very well how to deal with that. And I think there is research trying to, approach these different symptoms. And the reason why I'm concerned is that we are not ready yet for, all these symptoms. So we need to improve that. We are seeing that there is a huge rise of patients with IBD. Every week we are having a new diagnosis. And if we don't improve our way of having this holistic management, because it cannot be myself taking care of everything in the single consultation, it's not feasible. We are already struggling with time. So I think it really needs to, this concept of a multidisciplinary approach and management to the patient, that needs to be stratified. It doesn't need to be for all patients. There are patients that have a mild course and probably are feeling fine and don't feel this, kind of burdensome symptoms. But for some patients, we need to have the teams that are able to give the proper attention to these patients. And it can be nutritionists, it can be psychologists, it can be nurse. It can even be a support group, just feeling that someone else is living that. And Philippa said that, right? Philippa said, once I got in touch with this patient association, this is when I got my remission. It's not a coincidence that she says that. We as physicians usually, oh, it's okay. But it's not a coincidence. We know that there is a link between the brain and the gut. There is this neuroenteric axis that we don't fully understand, but the link is there. I have no question, because the patients keep telling us that. They keep telling us that, if they're not doing well in their external life, that they have a flare. So it's not, I'm absolutely convinced it's not a coincidence, but I think, we need to improve a lot in having this multidisciplinary approach. Otherwise, we will, I think, fail to provide the best care to patients, because there is really a wave, I think, of patients being diagnosed. So we need to kind of have the resources for that.
So maybe we should go for IBD clinics where we could have all the resources we need, right? I think that would be definitely the future.
Absolutely.
Okay. So we would have a lot to discuss here, but I think we need to move now to our patient stories. So I'm very happy to introduce Alexandra Hoventa from Romania. She's a volunteer in Romanian Patients Association, and also Olivera Kulic. I think I misspelled the name, sorry, from Serbia, which is also a board member for the Serbian Patients Association. Thank you so much, both of you, for being here. And I think we can start with Alexandra.
Hi, everyone. It is very nice to meet you all. My name is Alexandra. I am 25 years old. I am from Romania. I got diagnosed with Crohn's disease in 2022, about 3 years after my symptoms started. After I got diagnosed, I started to read a lot of medical papers about IBD, and it took a few years to understand what my body is going through and how I can help it feel better. There is no such thing as a magical guide which will tell us how to deal with every situation related to IBD. Each and every one of us is unique, and we have to listen to our bodies when something feels wrong. I collected my information on how to manage my IBD throughout these years with the help of my team of doctors, my family, my friends, and even my therapist. And I can say that I keep learning new things every day. I would like to tell you what resources I use, which I found very helpful in managing my IBD. First of all, right after I got diagnosed, I searched for a therapist, and it was the best decision of my life. My therapist taught me how to control my symptoms till I get home safely. I would start breathing controllably, meaning breathing in for 5 seconds, hold it for 3, and then breathe out for another 5 seconds. If I do so for at least 5 to 10 times, my symptoms will calm down. Also, me and my therapist made an emergency box for when I have an anxiety attack, which lays under my coffee table with 4 things each person needs. The first thing is something to hold, to touch. I got a stuffed giraffe because I love giraffes. The second thing is 2 phone numbers, so I can call 2 people that I love and hear their voices. The third thing is something to smell. I have a mini version of my favorite perfume. And the last thing is something to taste. I got Nesquik cocoa powder, which reminds me of my childhood when I was very small, and my mother would bring me a cup of hot cocoa before bed. These things help me activate all my senses and calm down. Secondly, I wanted to experiment of myself and see what would happen if I stopped eating animal meat. So I became a pescatarian, meaning I only eat fish. And for me, it was a very good outcome because the omega-3 acids from the fish reduces inflammation. My blood test dropped. I also had a very high cholesterol, and I noticed that my results are much better now. Also, I reduced the amount of sugar that I was eating, and I noticed that my calprotectin dropped also. For my lab results, my hospital keeps a journal of my tests and compared them from when I was in a flare to when I am in remission. So they can see the evolution of the disease. And I keep a journal on my phone with what foods my body allows me to eat and still stay in remission. Now I want to talk about the resource I would like to have access to, and I don't, and I think every IBD patient needs to. We will really need a travel insurance for chronic illness, which will give us priority to the patients to reach the bathrooms anywhere and everywhere. This summer, I was traveling by car and we stopped at a gas station because I really needed to go to the restroom, and the queue was about 30 people. And I couldn't wait that long, and I started to have stomach aches, cramps, symptoms specific to my Crohn's. So we had to stop at every gas station to find a bathroom available. I think this resource will really help the patients and could avoid having complications. To sum up, the most important things an IBD patient can do is pay attention on what the body and the mind wants. Mental health should be a priority for everyone, and keeping a food journal will definitely help our IBD journey. Thank you for your time. And if you have any questions, I'm here.
Thank you so much, Alessandra. That was a very inspiring talk. Thank you so much. And I think we can move to Oliveira also.
Okay. Hello, everyone. Can you hear me well? Okay, that's great. So my name is Oliveira, and my last name is pronounced Chuliberg. So it was impossible for you to pronounce it correctly. It's completely fine. I'm 27 years old. I got diagnosed with ulcerative colitis in 2022, which was 2 years ago, actually. Oh, 2021, yeah. And so basically, in the first year of my diagnosis, I was a pretty easy patient. So I didn't really pay that much attention on my therapy or my nutrition. I just basically followed my doctor's guidelines. And I really didn't think about it too hard because it really didn't affect my life too much. Unfortunately, my health turned for the worse. In a span of 2 months, I ended up in the hospital and having to take biologics and immunosuppressants, so cyclosporine, then vedolizumab. That worked for about 2 months, and after that, I ended up in the hospital again and again. So in the course of 1 year, I had 4 hospitalizations. I had severe complications, really difficult anemia. I had to receive multiple blood transfusions. And everything that happened to me that year actually made me motivated to join my association and contribute to the IBD community, both in my country and abroad. So after this brief introduction, I'm going to talk about resources that I use now, and also how are people in my life heavily involved in my disease management. So I call this my 5 pillars of IBD self-management, and I will talk about all 5 of them. So the first one is medication treatment. All of the information that I have about my treatments, I get from my doctor's office. My doctor is really knowledgeable, and he's also a university professor. He's really good at explaining things in a simple and clear and easy to understand way, which I really appreciate. Unfortunately, he's really busy, so I really don't have too much time with him during my checkups. But I make sure to use my checkups as effectively as possible. So I always prepare in advance, meaning all the questions that I have, I always write down. And then during my checkup, I make sure to ask them and to get his feedback. And this is something that I do constantly because questions are constantly popping up. This is not something that you can do one time. This is something that you will do throughout your life as you grow and as your disease grows with you in a way. So also, I get a lot of information about from my IBD nurses as well. I think they are really helpful because they sometimes work more closely with patients, and sometimes they have more time to explain different aspects about our treatments. Unfortunately, because my treatments were introduced really quickly, because I was in a life-threatening conditions, I really didn't get too much information about my treatments in advance. So all of the information that I got is something that I gathered afterwards. Currently, I'm on infliximab, so I'm still learning about this treatment, about the side effects. And I also realized that a lot of different specialties are involved. For example, endocrinologists, dermatologists. I actually gathered a lot of information about biological therapy from them as well, because I had some mild side effects from the treatment that I'm receiving. So basically, I also gathered a lot of information from Crohn's and Colitis UK website. I think that's a great website for people who speak and understand English, because they really make sure to provide a lot of resources there for IBD patients. This is something that I would like for my association to have as well. But I know it's a lot of work, and this is something that we in our association are really working hard to provide these resources to our patients as well. The second pillar, which is really important, and Alexandra already talked about it, is mental health. Same as her, I started doing therapy right after I received my diagnosis, because I was aware that I'm prone to anxiety and I'm prone to reacting harshly to stressful situations. So getting through my diagnosis wasn't something that I wanted to go through alone. Basically, now I go to therapy twice a month. And when my health condition was pretty severely difficult, I even went to therapy during my hospital stays. I would have online consultations with my therapist in the hospital. So this is something that really helped me and is still helping me a lot. I'm also doing EMDR therapy, which is used for trauma resolution, because my hospital stays were in a certain ways really traumatizing for me. So this is something that I'm still working on, but it is much better than it used to be. Also, I journal a lot. This is my journal, third this year. And I have some journaling prompts that I do every single month or every single day. For example, every single day before bedtime, I make sure to write 5 things that were good in that day. And it doesn't have to be like something big. It can be something small. It depends on how good I'm feeling physically. So it can be something as simple as I got out of bed and make myself a cup of tea, but it can also be some great accomplishment. That is something that keeps my mind on positive things and realistic things in my life, which actually helps in my mental health management. Also, my third pillar of health is physical activity. I'm doing yoga every single week, and through yoga, I learned a lot of meditation techniques and breathing techniques. The one technique that Alexandra mentioned, I use as well. Also, one technique that I find really helpful in stressful situations is a stop and look technique, which basically makes you stop in your shoes, look around, and be aware of your surroundings, and then focus on your breathing. You can look at your hands and touch them, so you stay connected with your body, and that helps me lower my anxiety levels pretty quickly in a span of maybe 1 to 3 minutes. Yoga is really great because of yoga practice, I became much more aware of my body and the signals that my body gives me in stressful situations. And this is something that I find really helpful in managing my symptoms as well. The fourth thing that is really important to me is my nutrition. As I said before, my physician is really knowledgeable, and he also really stresses the importance of nutrition. So he is recommending Mediterranean diet. But last year, I've also tried specific carbohydrate diet, which excludes all of the grains out of the diet. Now, I think that the diet is highly restrictive, so I'm not really sure how good it is in the grand scheme of things. But currently, I'm working on reintroducing some of the foods that I've been avoiding for a long period of time. But something that I'm really focused on is avoiding gluten, avoiding sugar. And this is something that really helps me. I'm not bloated. I don't feel any indigestion symptoms. And Mediterranean diet combined with gluten and sugar-free is something that has worked for me really, really well. I also make sure to meal prep every week. So I will use Sundays nights and Wednesday nights to prepare my foods in advance. That way, I make sure that I have all of nutritional foods throughout the week because I work 8 hours and I need to have all my food prepared in advance. The one thing that I find challenging is eating while traveling, because not all of the places and all of the restaurants have the foods that are like designed for my specific needs. But then again, it's something that I research in advance. If I have to like travel, I always research the places which serve food that I can handle and digest and eat, and that are nutritious and good for my digestive system. And the last thing, the fifth pillar of health, is my support system, which consists of my friends, my family, and my partner. I'm really vocal about my condition. I talk about it with my family members and my friends, so they are all pretty aware of what I'm going through. But I also made sure to put up boundaries with them. So some of the things I'm happy to discuss, other things I'm not. I really don't like people giving me unsolicited advice about how can I better manage my condition, because those advice usually come from people who are not aware of this condition pretty well. So this is one boundary that I make sure to set with everyone. And also some things that I'm missing. Well, actually, I would say that I'm pretty pretty covered from all of the sides, but a lot of the things that are available to me is because of my family's financial situation, which is pretty good. A lot of the patients my age are not in a financially good situation, so they can't really provide for themselves what my family provides for me. Mostly, I'm referring to expensive diet, expensive therapy, and also even my yoga practice. I have a yoga instructor, which is also expensive. So systematically speaking, I think patients lack a lot of resources. I'm not sure that we really need a lot of apps. I use, for example, my health app on my iOS Apple phone, and I track my medication there. But I'm not really sure that we need like a specific application for that. I mostly stress the use of journals, because those are really important to track your mental health and your thoughts and feelings and emotions. And I also think that talk about stress is really tricky, because I believe that certain amount of stress is really normal and in some cases necessary. If you have certain goals that you're working towards, it's normal to feel a little bit of frustration there. But I think the most problematic thing is like a chronic stress that can lead to anxiety and depression. And I think that really the talk about stress needs to be more nuanced. And I think a lot of the times you can hear advice like, oh, just don't stress. But that's not realistic. And then you can get in a vicious cycle of stressing, overstressing, which is not helpful at all. So I think this is something that really needs to be discussed in a more nuanced way. And that's all for me. Thank you all for paying attention, and thank you for having me. I had a lot of fun preparing this presentation for you, and I really enjoyed hearing stories from Candida, Philippa, and Alexandra as well.
Thank you so much, Olivera. Thank you so much, Olivera and Alexander. So I think we can see here that we can have a lot of different disease phenotypes, different symptoms, but there are some tools that are across all types of presentations of the disease. We talked a lot about mental health, diet, exercise. I would just like to ask Joanna, as a physician, how should we combine all this with the treatment of the disease? Is this complementary? I think it's important just to focus on this before closing the session.
Yeah, no, so I really enjoyed listening to Alexandra and Olivera. And I think I will also take this journal advice for myself, because I think it's helpful for everyone, not just for patients. So I think there's something important to mention. So we have medical treatments, and there's a lot of complementary treatments that can help patients in different way. And so I think both of you touched in different dietary manipulation or stress management, which is individualized, and that you found the best way to do it for yourself. It doesn't mean it's the best way for the other patient. And so I think something very important that I would like to stress is that it does not, of course, it depends on disease severity, what treatment you are, but I think these are very important to improve quality of life. It may help to manage symptoms, but just for the patients that are listening to us or may listen to us, it's not replacing the medical therapy if you need that medical therapy. And so I just wanted to stress that out. And of course, their patients are very interested about alternative therapies. And I usually say it's completely fine as long as you take your treatment, but also with the new molecules we have, small molecules, you need to inform your physician, because there may be some medical interactions. And so I just would like to stress that, from the physician side, for the patients that are listening to us. Thank you for the question.
Okay, thank you so much.
And thank you both for for sharing your experiences.
Okay, so maybe Professor Salome, we can.
Yes, so yeah, it's my time to wrap up and to close the session, but first to thank very much to my colleague and friend Joana Torres for this final session, and also for Alexander and Oliveira for sharing with us how are you dealing and your self-management tools, and to share with all of us. So it's my time to thank very much to all of the participants in this session, to the audience, and I just looked at the chat and the Q&A that we had the participation of many people from different parts of the world, and I'm very proud about that. We hear about some scientific news on where we are in terms of IBD prediction and prevention. So we will have a promising future ahead. I'm very confident about that. And overall, I hope that this symposium had fulfilled its main aim, which is to improve health literacy, to promote the patient empowerment, and also to constitute a forum where everybody brings together the different players in IBD equation, which is scientists, clinicians, patients, and society, to talk and to discuss and to bring the different domains of knowledge and experiences. So thank you very much. It was a great pleasure to host this symposium as the coordinator of the GlycanTrigger, and I invite you all to follow GlycanTrigger social media, because it's also a way of being up to date on how we are tackling IBD prediction and prevention. So thank you very much, and have a nice evening for all of you, and